Welcome back. So the last video we had spoken about a few drug interactions, that is the drug combinations. Here we'll be continuing with another combination, that is sildenafil or tabdenafil, nothing but the PDE5 inhibitors with nitrates. So now looking at this, the sildenafil, it potentiates the vasodilation. So the sildenafil, it's nothing but it does the vasodilation, and for the action of nitrates, vasodilation for the action of nitrates, and can cause MI and sudden death, and can result in MI or even death. Now if we look at nitrates, it should be avoided for 24 hours after sildenafil intake. So avoid nitrates, and it should be avoided before almost 24 hours before the sildenafil intake. Now moving ahead with the myocardial infarction. This is MI, and how do you treat it? So for treating it, you can use antiplatelet drugs, antiplatelet agents, preferably you have aspirin, and in case you are allergic to aspirin, you can also use clopidogrel, and you can use analgesia as well, and preferably morphine. Also you can use nitrates. It can be IV nitroglycerin as well, and you can use low flow oxygen therapy, and reperfusion therapy as well, and it is nothing but primary percutaneous coronary intervention or thrombolytic therapy. So there are many therapies here, that is thrombolytic, as well as there is percutaneous coronary intervention as well. And now I'll be quickly summarizing what I've discussed here. So here I've talked about drug interactions, that is drug combination, along with sildenafil and the nitrates. So here what is seen is sildenafil, it potentiates vasodilation. So vasodilation and of the nitrates, it potentiates the vasodilation and can cause MI as well as sudden death. And nitrates, it should be avoided for 24 hours after sildenafil intake. So nitrates to avoid after sildenafil intake. So in such a case, it cannot be used, it will potentiate it. And moving ahead with pharmacotherapy, what we have read is, in case of pharmacotherapy, the MI, the antiplatelet agents are used. Antiplatelet agents can be used like aspirin. In case you're allergic, you can use clopidogrel, and also analgesics such as morphine, as well as you can use nitrates. And there are low flow oxygen therapy that can be used. In case of nitrates, nitroglycerin can be used, and there is reperfusion therapy, that is thrombolytic, as well as PCI, that is nothing but the percutaneous coronary intervention. Now just moving ahead with the next page, we have also the treatment would be to give anticoagulants. So you can give anticoagulants. So I'll be continuing the treatment. Anticoagulants. So under anticoagulants, you have low molecular weight heparin, LMWH, as well as unfractionized heparin, and they should prevent the reinfarction and thromboembolic complication. So thromboembolic complications can be prevented. Thromboembolic complications are prevented. And also you can use beta blockers. Beta blockers should be administered within the first 24 hours. So you can use beta blockers as well. And what they do is they prevent the reinfarction as well as the arrhythmias, and also reduce the mortality as well. Now looking at the ACE inhibitors. Okay, inhibitors can be used, example ramipril, or even ARBs can be used, such as valsartan. And what they do is they improve the survival, increase the survival chances. And then we also have the statins, the atorvastatin should be started, and it reduces the thrombolytic events and the reinfarction. So decreases reinfarction. And next, acidosis, we can give IV sodium bicarbonate, and this is in respect to acidosis. We can administer this. Next, looking further, we'll be looking at drugs in CCF, how it is, what is used. So CCF. So coming to CCF, firstly we need to know the mechanism, the compensatory mechanisms of how the heart functions. So to maintain the CO, that is the cardiac output, these things are carried out, that is increase in sympathetic activity, as well as increase in renin-angiotensin system, as well as myocardial hypertrophy, as well as remodeling. So these are the important points. Now I'll be quickly summarizing with the page I've just discussed. So here you can see the pharmacotherapy of the myocardial infarction. So here what we have discussed is they have started with anticoagulants. So anticoagulants, and it can be low molecular weight heparins, as well as the unfractionized heparin that can be used. What it does is it prevents thromboembolic complications. And looking further, what we can also see is beta blockers can be given, and it prevents the reinfarction as well as the arrhythmias, and also reduces the mortality. Next, moving on to the ACE inhibitors, example can be ramipril. What this does is along with ARBs can also be given, and what it does is it improves the survival and it also ARBs and thrombolytic events and reinfarction are prevented in these. And next, moving on to statins. Statins, what we see is it can be used for secondary prevention to reduce the thrombotic events and reinfarction. Acidosis, it is treated with intravenous sodium barbituric, sodium bicarbonate. So sodium bicarbonate is present. It can be used in case of acidosis as well. Now looking at statins, it should be started early. Another point to note is it reduces the reinfarction. And ACE and ARB also, to make it simple, it just increases the survival chances. So we are done with this page, so let's move on. And also I gave a short note on the CCF, so I'll just be highlighting the same place. So the mechanism that are followed is it increases the sympathetic activity, increases the renin-angiotensin system as well as the myocardial hypertrophy and the remodeling as well. Now moving ahead, we'll be looking at some flowchart where it is explained very well. So now if we look at nitrates, AC inhibitors, so I'll be drawing this flowchart. Now we have the flowcharts. So firstly we have the ACE, ARB as well as the nitrates. So what this does is it reduces the preload. Okay, it reduce the preload, and then what happens is there's backward failure, distended veins with increased preload. So it increases the preload. And next, if we look at drugs such as digitalis and dobutamine, what is happening is there's increase in cardiac output as well. Next, if we look at drugs such as dopamine, it increases the renal flow. And next, if we look at drugs such as diuretics, what is happening is there is increased sodium and water excretion. Okay, so now if we look at the other side, what is happening? The ACE, ARBs and the vasodilators, what happens is it reduces the afterload as well. And in case of ACE inhibitors and ARB, what is happening is there's increased in renin-angiotensin activity. So due to this, what's happening is there is again it goes to the sodium and water retention. So to just make it simple, I'll draw a heart here. So imagine this is the heart. So then you're suffering from CCF, congestive cardiac failure. So there's decrease in cardiac output, and there's a reduced renal blood flow, and there is sodium and water retention, and finally there is edema. This is how it takes place. So here there is AC, ARB, they act here on the heart, and what we notice is there's increased in preload, and due to increase in preload there is decrease in cardiac output, and due to cardiac output is decreased, here we can use digitalis and dobutamine. So what this does is it increases the cardiac output, whereas in such a case where ACE, ARBs are used, what is happening is there is a reduce of the preload. Okay, so these things, they reduce the preload. So in case of an increase in preload, what they do is they reduce the preload. So next we're looking at reduced RBF, that is nothing but the renal blood flow. So in such a case, the dopamine, it increases the renal blood flow. In case of dopamine, it increases the renal blood flow as mentioned here. And next, if we move on to diuretics, the sodium and water are there, and it promotes the sodium and water excretion. So since I'll just summarize this. So basically in CCF there is decrease in cardiac output and reduced renal blood flow, and there is sodium and water retention, and there is edema. These are the common things. So at each stage, let me tell you what should be used. So in such a case where there is reduced preload or reduced afterload, what can be used is, in this case we can use ACE or ARBs. In case of increased preload, we can also use nitrates, as well as vasodilators can be used. Now moving ahead to the next step, that is decreased cardiac output. What can be used is digitalis and dobutamine. So digitalis and dobutamine, what this does, it increases the cardiac output. So it increases cardiac output. Next, a reduced renal blood flow. What can be used is dopamine. It increases the renal blood flow. And next, moving on to the diuretics, what it does is it promotes, it increases the sodium and water excretion as well. So hopefully it is very clear now. Moving ahead, we'll be looking at some important classifications of the drugs used in congestive cardiac failure. Classifications, I won't be dealing with the examples, but I'll be dealing with some of the headings. So you have diuretics, under that you have loop, thiazide and aldosterone antagonist. Next we have vasodilators, that is arteriolar, veno and arteriolar venodilators. Then there is also beta adrenergic blockers, sympathomimetic amines, cardiac glycosides, phosphodiesterase 3 inhibitors, vasopressin receptor antagonist, and also brain natriuretic peptide as well. So I won't be dealing in detail, that was already discussed. Now we'll be looking at diuretics, how it acts. We'll be looking at diuretics. In case of diuretics, it what needs to be known is it increases the salt and water excretion, and due to this there's decrease in circulatory volume, and there is decrease in preload as well. Due to decrease in preload, what is happening is it improves the cardiac function, as well as decreases the dyspnea and peripheral edema, and relief of symptoms of congestion, and relieve congestion symptoms. So now we'll be just giving a recap of what we have discussed. So we have seen the classifications, and it is nothing but there is diuretics. Under diuretics there's loop, thiazide, as well as aldosterone antagonist. And next we also studied vasodilators. We have arterial veno and arterial veno vasodilators. There's also beta blockers, and there is sympathomimetic amines. There's cardiac glycosides, there's phosphodiesterase 3 inhibitors, there's vasopressin receptor antagonist, there's also brain natriuretic peptide. So these classifications, and then we also spoke about the diuretics. Under the diuretics, there is what it does, mechanism. It promotes, increases the salt and also the water excretion. So increases the salt and water excretion, and next what it does, it decreases the circulatory volume. Okay, and then what happens is it decreases the preload, and due to the decrease in preload there is improvement in cardiac function. So the cardiac functioning is improved, as well as there's decrease in peripheral edema, as well as the decrease in dyspnea. Now moving ahead, we'll be looking at the vasodilators. So in case of the vasodilators, there is mixed arteriolar venodilator and arteriolar dilators. So what this is doing is, under mixed there is ACE inhibitors, ARBs, as well as sodium nitroprusside, And what this does, together it reduces the preload as well as the afterload. Next, we have the predominantly venodilating effect. So in case of venodilating effect, main thing is it acts on nitrates. And next, looking at the arteriolar dilating effect, what it does is there is minoxidil and hydralazine already been discussed. So I'll be again discussing because it is very important. Now looking at nitrates, what it is doing is, as we know, it is mainly venodilator, and then it also, there's peripheral pooling of blood, and ultimately there's a decrease in ventricular end diastolic pressure and volume, pressure as well as volume. Next, on the similar thing, we'll just quickly look on the arteriolar dilators. So here examples, we have hydralazine, minoxidil, nifedipine, just to name a few. So these are nothing but the arteriolar dilators. So if we look at the function of what it actually does, so there's decrease in PVR, that is peripheral vascular resistance, there's decrease in afterload, as well as there's increase in stroke volume due to this, and improved tissue perfusion. So now, as we are done with this, I'll quickly recap what we have done. So we just went through the vasodilators. So as we all know, the classification is important. So there's arterial, and under arterial there is examples being hydralazine, minoxidil, and nifedipine. Minoxidil, these are the main. Okay, hydralazine, minoxidil. And next, looking at the venodilators, there is nitrates, which are most commonly used. And looking at the arteriolar and venodilators, they can be ACE, ARB as well as the sodium nitroprusside. Now looking at the nitrates, they are mainly venodilators. They cause peripheral pooling of blood, and due to this there's decreased ventricular end diastolic pressure and volume. Decreased ventricular end diastolic volume and pressure as well. Now looking at arteriolar dilators, what happens is there's a decrease in peripheral vascular resistance, and due to decrease in peripheral vascular resistance, there's also decrease in afterload. Due to this, there's increase in stroke volume as well, and improved tissue perfusion. So this is important to note that arterial dilators, it decreases the peripheral vascular resistance and decreases the afterload, and due to the decrease in afterload, there is increase in stroke volume and improved tissue perfusion. And now we'll be moving ahead, and we'll be looking at ACE inhibitors. And under ACE inhibitors, we need to know that it is used in all common CHF. It is used in CHF as well as a symptomatic left ventricular systolic dysfunction as well. And they inhibit the conversion of angiotensin 1. So it inhibits the conversion of angiotensin 1 to angiotensin 2. So now looking at ACE inhibitors, it inhibits the generation of angiotensin 2, and it results in decrease in the peripheral vascular resistance, and it increases the stroke volume and improved tissue perfusion. So this inverse relation should be known, that is, decrease in PVR will cause increase in stroke volume. So that is so because of increased tissue perfusion, and there's also increase in renal blood flow, and this causes diuresis, and this causes circulating blood volume as well. And Next, looking at aldosterone production. Aldosterone production, what is happening is there is decrease in sodium and water retention, and due to this there is decrease in preload as well. Now moving ahead, there is decrease in pressure in the atria and pulmonary circuit, decrease in atria as well as the pulmonary circuit as well. Next, we will be looking at also the another point, that is it retards the ventricular hypertrophy and remodeling by decreasing the angiotensin 2 and the aldosterone levels. Now moving ahead, we'll also give a quick note on what is the ARBs. So we have the ARBs, that's nothing but the angiotensin receptor blockers. So examples being losartan, candesartan, and what they do is they block the AT receptors, angiotensin receptors, and it is present in the heart, the peripheral vasculature as well as the kidney, and they prevent the effects of angiotensin 2 and produce similar effects as those of it's similar to the ACE inhibitors. And also another point to note is mainly used in patients who cannot tolerate ACE inhibitors because of cough. So in ACE inhibitors, what we have is cough, angioedema as well as neutropenia. So to avoid such complications, we can use ARBs. Now I'll be quickly giving a summary. So here what we have seen is we have discussed from ACE inhibitors. So ACE inhibitors, it is commonly used in case of congestive heart failure and also in asymptomatic left ventricular systole dysfunction, and it also causes inhibit conversion of angiotensin 1 to angiotensin 2. So the conversion is inhibited. And looking further, we have also seen that there is decrease in peripheral vascular resistance, and due to this there's increase in stroke volume. So these are inversely related, and there is improved tissue perfusion. There's increase in renal blood flow. This causes diuresis, and there's decreased circulating blood volume. And next, we also seen the aldosterone production. Due to the aldosterone production, there's decrease in sodium and water retention. Due to this, there's decreased preload as well. Next, there's also venodilation. It also causes decrease in preload, and there's decrease in pressure in atria as well as the pulmonary circuit as well. Decrease in atria as well as the pulmonary circuit. Now moving ahead, we'll give a quick note on. We are giving a quick note on the ARBs, that is angiotensin receptor blockers. So as you know, it is nothing but the losartan, candesartan, as well as the other sartans, and what they do is they block the angiotensin receptors. And actually I've already discussed there, so I'll quickly mention it there only. So as we know, the ARBs, losartan, candesartan, and all the sartans come here. What is seen is it acts on the receptors of the heart, the PV, that is nothing but the peripheral vasculature, as well as the kidney. And then the AC inhibitors, it is used as an alternative, and because the AC inhibitors can come up with cough, angioedema as well as neutropenia. Due to this, ARBs are preferred. Next, we will be looking at some other topic, that is the beta adrenergic blocking. So a quick note on that as well. I have been repeating because it's very important. Adrenergic blockers. So here a quick note is you have examples such as metoprolol. You have all the LOL, bisoprolol. Okay, so what this is doing is it is useful in case of moderate heart failure, and there is a long-term therapy with these beta blockers. It improves symptoms and reduces hospitalization and decreases the mortality. So here we can see that the mortality is decreased. So decreased mortality decreases the mortality rate. And another point to note is that the long-term therapy with beta blockers improves the symptoms. Long-term therapy, it improves the symptoms as well. Next, we'll be looking at the mechanism of action. The exact mechanism is not clear, and what they do is the beta mediated effects on the catecholamines of the heart block beta receptor mediated catecholamines of the heart. This is to be known, and it improves the left ventricular structure and function. So it focuses on the left ventricular function. And other point to note is it increases the ejection fraction, as well as it decreases the left ventricular size. It decreases apoptosis, ventricular remodeling. They also decrease the frequency of arrhythmias. And it also has carvedilol. If you take it, has antioxidant effect. And under heart failure, if you use beta blockers, it should be done under supervision. So these are some important points of beta blockers. So I'll quickly recap what I've done. So beta blockers, example, I told you it ends with lol. So they have metoprolol, bisoprolol, carvedilol. And looking at the long-term therapy, in case of long-term therapy, we have seen that it reduces the mortality in patients having heart failure. And also the mechanism, it's not very clear, but it's believed that there's blockage of, so it blocks the beta receptor mediated effects of catecholamines of the heart. So what it does, it improves the left ventricular functioning, and it decreases the wall stress. So wall stress is reduced, and due to the reduce, there's increase in ejection fraction, and there's decrease in left ventricular size, and there's decrease in apoptosis as well as ventricular remodeling. And I'll just repeat the points. We have seen that it improves the left ventricular function, it decreases the wall stress, it increases the ejection fraction, it decreases the ejection fraction, and it increases the ejection fraction, decreases the left ventricular size, as well as it decreases the apoptosis, and as well as it causes the ventricular remodeling. Next, looking at the carvedilol. The carvedilol, it has a antioxidant property, and due to the antioxidant property, it is beneficial to use it. And in case of heart failure, beta blockers should always be taken under supervision. This is also important. Now, moving further, we will be looking at some other drugs, such as be focusing on the cardiac glycosides and its mechanism of action. And here we are. So there is cardiac glycosides. So in case of cardiac glycosides, we have the digitalis. So what is happening is the digitalis, it binds and inhibits the NAK ATPase. Because of this, there's increased intracellular sodium, and because of intracellular sodium, there is decreased extrusion of calcium as well through the sodium calcium exchanger, and this results in increased intracellular calcium. And due to increased intracellular calcium, what we can see is this increased calcium uptake and storage in SR, that is sarcoplasmic reticulum, and due to this there's increased calcium that is released during each action potential. So calcium is released during each action potential. So now I'll be due to action potential, and this leads to increased availability of calcium to the excitation, and due to this there's contraction coupling, thus increasing the myocardial contractibility, and it increases the cardiac output. So these are the points. So I'll quickly summarize what has been discussed here. So we spoke about the cardiac glucosides. So we have the cardiac glucosides. So what is this? We have seen the mechanism, that is in case of digitalis, it binds and inhibits the Na plus K plus ATPase. Due to this there's increased Na as well as Ca. The Ca, what it does is there's increased uptake and accumulation in the sarcoplasmic reticulum. Due to this there is increased availability of Ca for contraction, and it causes increased myocardial contractibility, and due to this there's increased cardiac output. That's all was discussed here. So thanks for watching, and next I'll be continuing along with the pharmacological actions as well as the other actions of the glycosides. So thanks for watching. In case you like it, give a like. Thank you.